of those. The one thing I mentioned is that the sphenopalatine injection is really the key block for your ethmoid work. And if you do a good sphenopalatine injection, which I just slide along the inferior edge of the middle turbinate, and when it turns lateral and attaches, right in that little crook, that's where I do the injection, and it diffuses really nice up there to the sphenopalatine branches. So that's the key on that. We do give a good bit of sedation, as you saw, and the patient is often very sleepy, not all the time, but I think it's important to monitor appropriately. And so we use this little device here. It's just a continuous 3-lead EKG. We take the blood pressure every 5 minutes, and we have a continuous pulse ox going. And so we're able to really stay on top of the patient's vitals, and with that, sometimes if you see some PVC starting, I'll pull the pledgets out or I'll stop injecting, and I think we've probably avoided some issues along the way over these years. We do have these reversal agents on hand. I think that's critical to have those. I've never had to use them, but you do need to have them on board. The flumazenil, obviously, for the benzodiazepine. It's very difficult to overdose a patient on benzodiazepine. And more importantly, it's very difficult to significantly depress their respirations on a benzo compared to an opioid. So that's the key. That's why you can use higher doses and have more confidence in that, because they just tolerate that much better. But you need to have these on hand. Afterwards, we just watch the patient about 30 minutes. And with the triazolam, it wears off much faster when we're done than we saw with Valium. And after about 30 minutes, they are ready to go. And of course, they have a driver phone, but they're ready to go. Thank you very much. Happy to have any questions or discussion. Any questions from the audience?
I think the lunch was too good.
Hello. So when you use this balloon sinuplasty to dilate the sinuses, frontal, maxillary, and sphenoid, and have you noticed it becoming stenosed over the years? If so, which sinus is most prone to become stenosed? Second part of the question, can this be used in any acute settings, i.e. in an acute frontal sinusitis?
Absolutely. Just to answer the second question first, I've done a lot of sinus abscess treatment with balloon dilation, and it's important to adequately irrigate the sinus. We have an antibiotic and steroid irrigation, and then afterwards we'll place gel that lasts 1 to 2 weeks with antibiotics and steroids in it, and that makes a significant difference. And then we bring the patient back 1 or 2 weeks later, depending on the level of their inflammation, and we can repeat that. So that's the only way we've been able to manage these acute sinuses is a very hands-on approach, and you've got to deal with that inflammation and infection in the sinus beyond just the dilation. But it's great because if they come in as a patient, we can do it right there in the clinic. And so it's very helpful and efficient to do it that way. As far as just the sinuses stenosing, if you think about, if you look at if you dilate that frontal sinus, with a 7-8 millimeter balloon, and you look up there, I mean, it's a beautiful opening, and you've not disturbed the mucosa, you've dilated it. And so, to me, the chance of stenosis is much less than when, as much as I try to do a minimally invasive FES, the disturbance of the mucosa is always greater with the cold instrumentation. And so I think the degree of stenosis or the chance of it is higher. And again, it always depends on what the process inside the sinus is doing and what's happening there. If we don't manage that, then that risk of stenosis goes up.
I'll just add to what Andy said. I think your ostium is going to stenose as a result of a technical failure. So it would be something I've done. So when you're dilating the maxillary sinus, if you tear or you're too aggressive with your balloon insufflation, you'll tear your uncinate process. If you tear the uncinate process, then you're better off excising the uncinate process. Because once you've torn it, there's a risk that you will scar or form an adhesion laterally. Andy made a great point there about mucosal trauma. So again, the dilation technique involves up into the frontal recess, you're crushing the agonizing and any supraagar cells. And so long as you are atraumatic in your balloon insertion, then the risk of stenosis in a well-selected, well-prepared patient should be minimal. And you shouldn't have to then go back and revise either balloon or the cold steel procedure. Frontal sinuses, yeah, but patient selection is really important. Okay, so I would use it in a child, for example, 12, 13, 14, with recurrent acute frontal sinusitis. I think if you have complicated frontal sinus pathology like mucoceles, you have to recognise that, because I don't think it's then an appropriate technique for you to use in that sort of situation. So I think patient selection is key with regard to frontal sinus therapies.
I would just add post-operative care as well. The nasopor with steroid is a game changer, definitely in my practice, reducing it. I agree with my comments. Any other questions? So I'll wrap up this meeting by saying thank you to Stryker for sponsoring the event, and Michael Logan and team for organising it, and to my colleagues Bhalla, Andy Wells and myself. Thank you for listening to us. Have a good rest of the meeting.